Welcome back to episode 13 of the Rehab Exercise and Sports Therapy podcast, sponsored by University Orthopedics. I am thrilled today to be joined by Chuck Thigpen, who I have had the pleasure of knowing for a very long time. And I just told Chuck kind of off air, we could have talked to him about a multitude of upper quarter and therapy-based subjects, but we're going to try to pin him down on rotator cuff-related themes today. So Chuck, if you could give us a little bit of background about your role and kind of your background professionally.
No, thanks, Dan. I really am excited to be here. I think what you just called me is old, but I won't hold you to that. So I currently serve as the Chief Clinical and Strategy Officer for ATI Physical Therapy. We're in about 24 states, 850 clinics, and we also have an ATI Worksite solution, which is about 200 on-site early intervention occupational medicine clinics on-site with large employers across the U.S., as well as about 100 schools with certified athletic trainers providing sports medicine services in places. So in a lot of places, I kind of have two buckets. I've got our clinical excellence team that really does our practice standards, quality improvement, and continuing education and development, including our residency and fellowships. And then I lead our strategy team, which is really around strategic partnerships, our real estate expansion, just how we're growing our footprint, as well as our products and services of bringing high quality therapy to folks. But my background, I'm a physical therapist and athletic trainer for right on 30 years now. I started at the University of Tennessee, Chattanooga as in an internship exercise science program, kind of very classic early mid-90s, how you get into this thing. I was in the first physical therapy class at East Tennessee State University, and then later got my master's and PhD at University of North Carolina, Chapel Hill. So that's kind of how I got into research and clinical practice. Did a lot of biomechanics stuff early, shoulder, scapula, all that kind of stuff. I told somebody I'd been asked to give a career talk, which again, I haven't learned, found anything or big discoveries. I think relatively at least contributed. We know that GERD alone doesn't cause arm injuries, and the scapula isn't the answer. So I don't know what it is. I hope Dr. Kibler doesn't listen and find out I said the scapula is not the answer, but it's been a lot. And so, over that time, I've had a variety of roles, but really I feel blessed to lead work with the team at ATI.
You just got yourself cut from like the next 10-year update on the Throwers article, right?
No, for sure. I'm in trouble with him for sure on that the scapula is not the answer.
Yes, right. And if it makes me feel like I'm old enough to remember like 2 companies ago when you were like based in South Carolina with Pivotal or ProAxis or whatever it was.
ProAxis, yeah. No, that's right. Yeah, that's right. Back in the beginning when I first came here, for sure. That's right.
All right. So Chuck, we could go in like a multitude of different directions. And since I have you, and since you have done a ton of extensive research on all things shoulder, I wanted to kind of go non-op and some post-op stuff if we could. So I wanted to start out with non-operative stuff because I feel like, again, as insurance algorithms continue to kind of dictate, unfortunately, so much of what we do from a PT standpoint, we have a ton of patients that come to us where PT is kind of the frontline treatment before the authorized MRIs and that kind of thing. So we get a multitude of patients who, are not so far down the screening road that we know exactly what's going on with them. So I wanted to try to find out in your mind, who do you feel like is the ideal candidate for non-operative cuff rehab or conservative management? If you get, again, like just some kind of risk factors, demographics, who do you feel like is the ones that will kind of succeed and benefit from it?
Yeah, so then I'll say it's probably one of the 2 or 3 areas that if I look back over my career, I'm like, I never thought I'd be an advocate of that. Just from the standpoint, like mechanically, I think you actually said this as we were trading notes back and forth, like the cuff's gone, like it's torn, like theoretically, right, from our biomedical model, you should fix the cuff in order to function. I think what we've learned is both from Dr. Yamaguchi's work and then, of course, Jed Kuhn and the Moon Studies seminal work that has really shifted the whole perspective is that it's true, except what we forget in therapy and in medicine, we're only seeing the patients that seek care, and we're missing all the people that don't. So I think the first thing I think about is who are the people that are walking around with cuff tears and have a little shoulder pain and they just manage it. And I think that's probably the gap for us that we miss of what do they look like. So I think, and the reason I say that, I think understanding from Dr. Yamaguchi's work where they did, bilateral shoulders, one had a cuff tear, and I think it's 56% had a tear on the other side, but guess what? No symptoms. And we know in post-op cuff, 30 to 40% don't heal or look funky, whatever you want to say, but most are fine, right? Like the healing has nothing to do with it. So I think we have to take that at least into context and think, okay, to me, I've shifted it from when I see a patient, my question isn't, how am I going to get through this little bit of therapy so you can go get surgery? It's actually for which patients with a cuff tear do I need to identify early because I have no shot, right? And I think we do this fairly well with, I think about radiculitis or, nerve impingement stuff. Like we have a pretty good, no, if you have these signs and symptoms, you go directly to the surgeon, do not pass go. But if you have this set, you know what, actually it doesn't make sense, but you ought to hang with me for a little bit. So I think that's really where I try to start and bucket patients with that. And I think probably the three things I look for are activity level. Is your number, so the more active, the less chance of me, helping you to do that. What was their pre-state? So before you had this problem, were you perfectly fine and then one day you just couldn't lift your arm and it's pain limiting? Or was there a point in time you had a trauma? No, I fell, the door, and now I can't lift my arm because I'm weak. It's not pain. So I think both what Dr. Kuhn studied and sort of my experience in doing this. So one of the things when I was fortunate to work across the hall from Dr. Hawkins, everybody came. It wasn't these patients that were, because of insurance avoiding surgery, they were large full thickness cuff tears in patients that couldn't or didn't want to have surgery and wanted another option. And so Hawk would they get a steroid injection and go across the hall. And I'm like, I can't get this person better. And what I learned is, I can make your pain better, either me or a steroid. If you're relatively low demand, i.e. you don't want to do a bunch of overhead work and throw a ball and that, and weakness isn't your primary complaint. Those three things are true. I feel like I have a pretty good shot to get you better. And I shouldn't forget the last and most important, which is, do you believe therapy will work? Right? I think it's actually the most salient piece is that and it's shown up a few times, right? If they think therapy will work, it does. I don't like it. I spent a long time learning how to be a therapist, but there's a little salesmanship and patient buy-in here to get that. Those are probably the things I look for.
Yes, perfect. You beat me to that question because that was one of my points down the road is, that buy-in from the patient, again, especially in this day and age where, everyone is convinced that the MRI is the end all be all, right? Oh, I have to have the MRI, right? And sometimes I tell them like, that's fine. You can get your MRI, but in a sense, it may not change what we do, right? We're just treating the impairments. We're treating the weakness. We're treating the loss of mobility, that kind of thing. So you can get your MRI, but it doesn't necessarily change what your home exercise program is going to be. So
for sure. And I think that's really the important thing. When we think about, we've actually, working with Dr. Ellen Shanley, she leads our practice standards and quality improvement. But we've actually tried to systematize exactly what you said, because I think too many times we're like, oh, rotator cuff tear, this is the treatment. Well, actually, I don't really care that your cuff's torn. Like, it's important. It's nice context. Sure. So what I actually want to know is, what's the primary reason you're here to see me? Is it because you have pain that keeps you up at night, right? You can't sleep? Is it Is it because you have a mobility issue and you don't have enough motion to get what you need? Or is it a stability and strength issue that you need? And I think we do that clinically when we're giving a program, but I think we miss the fact that there's pretty good research against different body regions that blocking and tackling, for those that know me, that's my favorite thing, but like the basics get people better. And I think, so really kind of bucketing down to what you said, Dan, so those kind of three buckets and that focus and progression allows the patient to manage their expectations and see some improvement, and helps us to make the right decision of, hey, like maybe you'll do okay. Actually, I saw a patient this morning. She's probably my most active patient ever that has a full thickness cuff tear. And she's probably 12 years out now, but she's super fit, Pilates instructor. Like she's actually the antithesis to what I said, because I don't know that I would have thought a personal trainer Pilates instructor that does 4 classes a day. And she's ripped. Like she is a phenomenal physical specimen. I don't know that I would have said, oh yeah, you'll be fine. You're okay. And she's like, yeah, I don't have surgery. I'm like, what do you mean? She was like, am I dying? I'm like, no, you won't die from this. She's like, okay, then you're going to rehab me. And I'm like, yeah. Oh, here we go. But it comes back to the adherence piece. But I saw her at the gym this morning. She's doing great. She's like, she goes, I dog jerked. I had a little pain. She goes, it'll be fine. I do the exercises and it gets better. So it's super interesting, right? Like, and she had big full thickness supraspinatus. At this point, I'm sure it's retracted and gone. But like, she still does Pilates, 10, 12 times a week. So anyway, I realize that's one, right?
Sure. But but we see patients with a similar presentation like that all the time, right? That they come in, with what you would deem as like, oh, this person is clearly, headed towards something surgical, and some of them deviate down that path, but then a decent to touch base with you is to find out, you just alluded to a little bit, but like obviously every patient presentation is going to be different, and you have to customize the rehab to that individual and what their impairments are. But for you, what are your kind of big rocks for conservative management? What do you feel are the essential pieces or kind of keys to success for you?
Really good question, Dan. So the first thing is you've got to manage the pain. So I think plus minus steroid, and like there's a lot of interesting takes right now on even if they get a shot out of the gate. I think most of the surgeons that I know and work with are still pretty aggressive early, with the caveat of unless they think they're going to need surgery soon, they may hold off, because most surgeons want at least 6 to 8, probably really 3 months post corticosteroid before they do surgery. What's interesting is, but managing that pain. So it's self-education, self-modification, but I think it's really this question around sleep, which a lot of time patients aren't really good at articulating, and helping sort out, does your shoulder wake you at night because you like to sleep on it or being funky, or you're at rest and your shoulder wakes you? Because I think that's actually a really important tell sign and piece to let. If you have waking pain at night and achy, I don't know if I can fix that. Maybe, but I don't know that it's because it's not a mechanical use over piece. So I think really sorting that out and helping patients understand what's driving their pain. And then it's just what you said. Typically most patients, mobility doesn't tend to always be a problem, at least to the glenohumeral joint. Yeah. Usually I can help them cervicothoracic to get a little extra help from their kinetic chain to get their arm overhead. And then for me, I go all the way back to the basics. Every cuff patient starts in supine, with whether you call it a Jenkins program from out west or, an I forget, South African surgeon that published it, but it's all the same. It's the levered program, short arm punches, deltoid program, lawn chair, whatever you want to use to work backhand. Because typically most patients, if I can get a little thoracic motion, I can get them started on a lawn chair program, and then probably a little external rotation, I can get their arm overhead pain-free. And so, that's probably 4 to 6 weeks. And the patient's got to understand this is every day. This is every day training that deltoid and what cuff you do have to offset. And then I think as they progress, then really pulling in some forward punches, some gripping, however you want to engage co-contraction of the posterior cuff and subscap to get that arm overhead, because that's really probably in my mind, mechanically, the go left, go right, you're either going to be successful or not, is I got you pain-free. Now can we learn how to load for what you need to do? And so it's really this forced coupling of the subscap and infraspinatus to get the arm overhead. So whether it's, closed kinetic chain, bands, there's a number of ways to do it, but however you like to approach it. And then once they can do that, now they're pretty good. And so I think for me, I expect a patient on or about 6 to 8 weeks. Well, for sure, 3 to 4 weeks directionally, you either, yes, you're getting better, or like, I don't think this is going to work. Like the trial of PT, if somebody really leans in, they modify their activities, they're managing their pain, and they reasonably participate in a home exercise program with a few clinical visits, they should be getting better at 4 weeks. If they're not, you got to call a timeout, call your surgeon. You and I were talking about Dr. Owens. Hey, Brett, I don't think it's going to work. Like, when do you want to see him? Right. Or, hey, they are progressing. They've improved in this. I'm going to give it another 4 to 6 weeks to give them a shot. And then I think it's just how high is their activity level? How much do they want to do from that standpoint? So those are kind of the guardrails that I think about. And it's really, I think about the patient where I alluded, she reminded me, like, she still does her bands and her maintenance program every day. So I think the other part for this population is they have to understand this isn't a one-time fix and, you go in with like, this is actually like, hey, if you want to avoid surgery, here's your program to do that. And this is how you're going to function, on the go forward, as opposed to, hey, I'm going to show up for therapy, I'm going to do 6 weeks and I'm all better. Like, this isn't a condition that I think 4 to 6 weeks of PT fixes everything.
Right. Yeah, for sure. So you alluded to a little bit already, Chuck, but I wanted to kind of get your thoughts on, you mentioned kind of getting that buy-in from the patient, or that, therapeutic alliance, if we want to call it, or whatever your buzzword of choice is, right? You have the patient that comes in with their MRI, right? Which, again, shows 8 million things wrong, because the radiologist is going to cover themselves from anything litigious, right? So they've labeled anything that looks slightly askew with that shoulder, right? But you find, again, that what you see clinically may be incongruent with that. But that patient is adamant, right, that they need surgery because the MRI shows this, right? So what do you do to foster that buy-in with the patient?
Yeah, I think probably 2-3 things. The first is, I cite some of the population literature, and the nice thing is with the Google-forcation of society, like, I love, oh shoot, he was the running back with for University of Colorado coach. We said, hey, you can Google me, when he was like introducing himself. Anyway, I forget who he is, but right. I tell patients, hey, you can Google this, but typically if you're over 50, 60, 70, if you're over 50, half of patients your age have a cuff tear.
We'll have a cuff tear. Yeah, exactly. If you look at an MRI, right, it's going to show you have a cuff tear.
And half of the people show up for therapy and surgery, and the other half never have a problem. So you're in this half. And I go, if you're 60, it goes up again. If you're 70, it goes up again. Like, it just, and so I call it gray hairs of the shoulder, however you want to think about it. Yeah. Typically, most patients appreciate that, as I do. I'm 52 now. Like, I wake up, I'm like, why am I so sore today? I didn't do anything. And so I think most people resonate with that. And so a little bit, I think it levels that. And I just encourage them, go ask Google or ChatGPT now, like, hey, how often does rotator cuff tears happen in the population? And so then I think it allows that. And then the next is, what are your goals? And I really try to then start to link their goals to then the last is their physical capability, right? Because I want them to see that, I'll talk to them about, hey, you got 4 rotator cuff muscles. This is what they do. And you've got other muscles that do this. There's 17 muscles that attach to the shoulder, and just try to break it down into really pragmatic. They're like, oh, I can externally rotate. Because right in my mind, if you can give me external rotation and hold external rotation into elevation, like,
something's functioning. Right?
I got a shot, right? I've got a puncher's chance at getting you better. And so I think that allows them to then connect, hey, this isn't everybody. This is my gray hair. Here's what I want to do. And here's some sort of here's some goals of how my shoulder needs to function to do what I care about. And I think I go back to like, who's going to do better? Because, right, like if pain and low levels pretty good, I got a shot. But if you're like, no, we had a period of time we took care of a lot of special forces and some other military folks, like they don't do well with this, right? Because guess what? Holding a 50 caliber and oh, by the way, if you drop it, you die. Yeah. Like, probably not the best. No. That's probably not a goal that matches non-operative care, right? I'm being a little silly, but so I think that makes it very pragmatic for the patient to walk away and go, okay, like I got it. I know what I need to do.
And I don't know what you're supposed to, I mean, I find despite the fact that, like you said, the information is so readily available now, I find that for me, there's no orthopedic injury that's still like as nebulous and poorly understood by the general public as a rotator cuff tear and mispronounced, right? Rotator cuff, rotor cuff.
Yeah, that's right. You have rotary cuffs up where you live? I thought that was just a Southern redneck problem.
Yeah. And I think sometimes, like when you sit down, like I've got an app that pulls up all the anatomy, like I'm sure half our viewing audience does, right? But when you actually show somebody like, this is your rotator cuff, right? It's these 4 small muscles that are responsible for kind of stabilizing and centering the head of your humerus and the glenoid. And then you can pull up and like overlap the size of the deltoid on top of that. I was like, that big muscle, that's why you can still raise your arm up, right? So if we can get a little bit of stability in there, right? And let that deltoid do its thing, we might be able to, like you said, have a puncher's chance. But I feel I'm sorry, go ahead.
No, that's exactly it, right? It's just like knee OA. You're like, oh, I've got a big bone spur. Like, I can't walk. I'm like, well, you're doing pretty good the last week.
Yeah.
Like, what changed? So I think but it's a little bit of just our mindset and understanding where our bodies are and how they change. And I think part of it is sometimes you're like, am I crazy? Like, right? Like, legitimately, like, hey, like it's a little bit of muscle. Like, why is it so debilitating? And I think it allows people to kind of dial in to like, why are they really there? Because what I'm fascinated by is how many patients I'm like, hey, are you okay? Like, can you do everything you want to do? Can you sleep at night? So, right, like there's a patient acceptable symptom state, just simply go like, hey, if nothing changed today, would you be okay? It's crazy how many times they're like, yeah. I'm like, why are you here? Because I had a torn MRI, or I had a torn cuff on my MRI and the doctor told me to come. I'm like, yeah, you can do everything you want. They're like, yeah. I'm like, you're good. Call me when you're not.
It's not a fatal, it's such a fatalistic injury, right? Again, kind of life or death based on what that MRI shows, right? And that's where I feel like the education piece, like I said, to kind of get some of that buy-in and just clear up the picture for them is so invaluable. But yeah.
For sure.
So, okay, so you gave me kind of what your time frame is as far as cutoff for like when the drop date is for like, if you haven't seen it by this point, it's probably not happening, right? And referral to surgeon. You alluded to a little bit as far as the injection piece, right? Tell me, like, who do you think, what's your general view on them? Do you feel like it's something that you should try it first with the exercise-based approach before you jump to the injection? Or you mentioned kind of the pain.
It's all about pain, right? It's pain and how fast you want to get better. I mean, there's really good evidence that shows whether it's Kinalog and whatever the mixture of pain and steroid is.
Yeah.
Because I think what we miss is it's actually 2 things, right? it's diagnostic. It confirms that your subacromial and or biceps pain is what's driving your pain. And it's super important. So I think it depends on the surgeon and the group you work with. Are they subacromial? Are they interarticular? You know, do they go after the bicep? It's actually a really important question for me when a patient's had an injection. Where was the injection? And then what I want to know is, how did you do immediately in the 30 minutes after?
Right.
Oh, I was just right. Like if they get all their pain gone and they were great, independent of a steroid flare and a little flare up after, it's game on. I can get that patient's head, arm overhead, pain-free at 6 weeks. Now, will it last? I don't know. Can they do their goals? I don't know. But like, it's a really good predictor in my experience around that piece with the injection. So it probably is apparent. I am a proponent. If pain is your number one thing, I think the diagnostic injection clarifies sort of the recovery path and your likelihood to respond. And frankly, it makes my job easier. Like, right, like I can get your pain better, but I would a lot rather have a little facilitation and pharmaceutical help to do that.
Sure, absolutely. So tell me, like, based on that information, how do you then take that and tease out biceps versus subacromial irritation and kind of what the pain, quote unquote, generator is, or that kind of thing, Chuck?
It's a great question. So, you know, if it is more biceps isolated, I think it gives me a good sense of, is the biceps substituting? I'm fascinated by the long head of the biceps because it's such a cheater and a pain generator. And so I think if you have a patient that, in my mind, that the long head of the biceps is adapting and substituting for cuff weakness, you see it. And so the easy way for me to see that is if I let a patient supinate and turn their thumb out with external rotation and they get stronger, and then I turn it in and they get weaker, then you know that their biceps is contributing. And right, like it's kind of
doing
basic.
All the work, right? Yeah.
But right, we're back to like basic, literally, for me, 1995 kinesiology manual muscle testing class, right? Like,
yeah.
I think we forget that sometimes to tease out, but it's actually a really important piece because I can do two things now, independent of our pain test and provocative test to guide us. Like, I don't really care, except for it now changes of how I'm going to strengthen it. It highlights that, hey, external rotation strength, for whatever reason, is a huge thing. Now, is it because they've got a huge cuff tear and they have no infraspinatus? Maybe, right? But that tells me then, okay, that means I'm going to have to spend a bunch of time in prone teaching their posterior deltoid and teres minor and middle deltoid to offset for whatever else I don't have in fourth generation, right? So I guess what I would say is that becomes, yes, biceps, okay. When biceps, is it overhead? Because I'm, you know, I've got some impingement-y kind of things, or is it actually, it's because it's a compensatory effect and it's down low. So I think that becomes a separator for me to really tease out. Yes, external rotation, but then where external rotation in the arc? Is it down low? Or is it this other group that it's really as I get overhead and typically don't get enough external rotation, right? So the tell is they lift their arm overhead, you can see their palm, or they're even almost full can. It's because they can't actively external rotate. They can't, well, and probably more correctly, they're not able to resist the internal rotation moment that pulls their hand in. Sorry, I did, theoretically, I have a degree in biomechanics and I should go back to that. So, right, so right, it's actually, and I think it's important because it's not concentric external rotation is not what I need to function. What I actually need is I'll use a Ben Kibler term, an isoeccentric function of the cuff to maintain external rotation as I elevate. And I think we miss that, right? Because the pec's such a powerful elevator and it's pulling the arm in. I just have to offset this huge moment arm of the pec as it elevates to be able to allow for full pain-free elevation and maximal subacromial. Sorry, I just went super deep on subacromial space.
No, I love it. I mean, hey, we're a very pro shoulder geek podcast here, so this is
That's good. Well, I am the geekiest of the shoulder geeks.
Yes.
I love the geek on the shoulder.
That's why we went after you as the guest, Chuck. So,
All right, good.
So no, I mean, I think, like you said, I mean, I tell people all the time, I'm like, the job of your rotator cuff is to keep that humeral head centered in the glenoid, you know, in a variety of different planes as you move the shoulder. And if you're not getting that, if that humeral head is riding up or down, then like you said, I think that puts even more stress on that biceps to act as the humeral head depressor, right? So I think I see it all the time in people where, like, you know, they've got a full thickness cuff tear, but where they tender, like right in the front of the shoulder at the bicipital groove. So yeah, I mean, I always, I'll never forget, I was in a grand rounds lecture and I had a younger surgeon tell us that he just, you know, without any real differential diagnosis or arbitrary nature, just kind of tenodized the biceps, the tendon on everybody because he felt like it was the pain generator. I'm like, well, I'm pretty sure it has a biomechanical function. I don't know if that's the best decision, but yeah.
It is. I mean, look, and I come from the land of the biceps killers, right? Like Hawk spent some time in France and, you know, he was pro tenotomy, tenodesis guy with everybody, but I think it does have a function. So if I'm in this non-op place, like, you got to give me a chance here, right?
Right. Yeah, for sure. So I mean, we could talk conservative management all day long, but obviously with you as a resource and some of the research you've done, I want to get into post-op stuff as well.
Oh, great.
Especially, you know, since we have a physical therapist that's done a ton of clinical research on here, I always love kind of being able to kind of sift through the variety, the 8 million different post-surgical protocols we see, because every surgeon is kind of married to their protocols, but we know that they're pretty diverse and all over the place, right? I mean, even within our practice, I can tell you, we have some surgeons that start them post-op week 1, like at day 3, with active assistive stuff and passive range of motion because their primary fear is stiffness. And then we have some that'll lock them up in a sling for upwards of 6 weeks, won't start them in PT until after that because they're worried about the healing. So I guess I want to kind of go sequentially here. If I could get your thoughts, when do you feel like, based on your research, is kind of the ideal window to start PT following a cuff repair? And again, I know it's going to vary whether you've got a massive or large tear versus a small or medium tear, but kind of give your general overview if you can.
No, I'll do the best I can. I think what I've probably evolved, maybe devolved, of how I think about it, in that the longer I do this, the more simple I get. And
Yeah.
I think it really comes down to a couple of questions. One, and you hit on it, right? It's so, in my experience, surgeons kind of have this bipolar reaction, and it's probably tied to two things. What is their quote unquote typical cuff repair, right? Is it small, or is it on the smaller side or larger side? And now, especially, like, how aggressive are they with biologics and patches and some of the new things that are out that give them confidence in the construct and their ability to load it? So if they're on that end of the spectrum, stiffness is what's in their mind. And the worst thing that could happen would be stiffness, and they have an approach to that that may or may not include therapy. And on the other side is a maybe less invasive, aggressive surgical approach. Yeah. Some might say more traditional, that or the other is they're going to repair everything. And they're like, look, the only bad thing that can happen here is it not heal. Everything else will get better. And so I think those are the two ditches around protocol. So I think it's really important to understand what's the surgeon's mindset. And frankly, on us is why are they not as aggressive as we think they should be, or vice versa, more aggressive than we're comfortable with? And usually it has to have, just like all of us, it's that worst case. We all have a patient in the back of our minds within a population that drives how we manage that population.
Sure.
And so, right, like I think, and the surgeons do this. And oh, by the way, guess who gets yelled at when a cuff fails or a cuff gets stiff. It's not the therapist, it's the surgeon. So I think understanding a little bit behind the surgeon there allows us to understand those ditches. But then, I think for me, typically I want to get a patient moving. In some, I don't believe there's actually passive motion. So if I just kind of put that out there, but look, every patient in my mind is going to be moving their shoulder immediately, but for sure at 10 days to 2 weeks, right? By the time they come back for the wound check, I've got to be moving the shoulder enough to allow them to function. They're bathing, they're coming out of their sling and whatever. So in my mind, out of the sling, pendulums to some 70, 90 degrees, and external rotation to 0 to 30, depending on the integrity, are kind of I don't know why any cuff wouldn't do that, because they're probably getting that motion anyway. And I think it likely, if you look at the research that's there, moderate sling use coming out of the sling, some sort of pendulum or table slide activity to 70, 90 degrees, and external rotation to 0 or just beyond 0 has almost 0 stiffness, even in the most stiff patients. So I think then it allows me to take that stiff patient off, right? So I'm thinking about, hey, worst patient. So I've taken the stiff complication off, and then now I think it becomes really important to align with the surgeon on the size of the tear, quality of tear, from a active assistive to loaded progression, because that's the window, right? And it's really 2 buckets of patients. And the smaller patients, if you look at the research, the risk of tear is not in the first 12 weeks. It's in that 12-week, that 3 to 6 month phase. Why? Because they stop coming to therapy, they start doing life, and they load it. That's when they tear. However, on the other side, the larger tear, and I'll call it 3+, that large to massive tear, when do they tear? They tear early. So that's the patient that is, I'm a little slower, don't be aggressive, because there's no win, right? There's not a win, and in particular, in that massive and large cuff, if that happens, now I'm looking at a reverse or some biologic augment. There's not a good outcome if that patient fails. So I guess that's how I think about the 2 ends of the spectrum, and then how do I mitigate against that with my post-operative program. And I think those questions allow us to ask the right questions for the surgeons that, in my experience, the surgeons are happy to engage about. They're actually super excited that you come with those questions instead of, both sides. We can all be very pejorative in our opinions and what's going to happen, right? And the reality is, probably given that the patient belongs to the surgeon owns ultimate accountability, coming with good, curious questions can allow us to get to the right protocol.
For sure. Yeah. And I feel, again, having been on both sides of it, early in my career, where I did not have access to post-op reports or intraoperative information about the MRI and whether or not they had fatty infiltration. I do feel like even just knowing the size of the tear, right, is invaluable. But I can remember nightmares, just too many scripts like arthroscopic cuff repair. Okay, well, that's great, right? But did you do subscap? Did you do posterior cuff? What was the size of the tear? So I do feel you're right. I mean, I think at least asking for that info, just for the surgeons that are even, are happy to provide it, if it means, again, that it's going to improve the outcomes for their patient or reduce, like you said, getting yelled at, at the follow-up.
It is, and I think actually, look, I'll just be honest, it's amazing. So one of the things of having 850 clinics in multiple states, it's amazing. I would say probably 40 to 50% of our patients come with a post-operative protocol, or I'm sorry, a post-op referral, but no definitive protocol and limited information. So I think it's actually, it's one of the things we talk a lot about in our practice. How can you engage the surgeon to understand why you want to know? Because depending where they're trained and their background, they're like, oh, just do the cuff rehab, because maybe they trained at, University Orthopedics where you guys are at. They're like, I don't know, the therapists know what to do. I don't really know. I just send them next door and they come back magically better. So I think it's just really, it's actually a really important way to engage and, you know, for me, have that professional level discussion that we want to have with our surgeon peers.
Yeah. And as, I mean, it's educational for the therapist also, because, you know, the surgeon may give you some insight into their thoughts about why they did it a certain way, or they use double row, that kind of thing, you know, and the fragility of the repair, you know, where who they feel like you can push, who they can't. So, yeah.
100%. Yep, that's right.
Yeah. So tell me a little bit, you know, you mentioned SLING, right? And again, just like anything else now, right, as we evolve, right, there's abductor pillows, right? There's people that are kind of being put in a neutral sling position, right? So tell me your thoughts about that. Let's assume posterior cuff repair, like, you know, infraspinatus, supraspinatus, like the majority down the middle, not
I mean, look, I see SLING as probably three things. There's reasonable literature that says it doesn't matter to cuff integrity, like and the repair techniques now it's probably not protecting. So you can debate it, but like it's hard to make the case that the sling's protecting the cuff. What it does do in my mind is two things. It does, I think, make the patient more comfortable. And when wearing correctly, it keeps pain under control, because like pain's my enemy to get easy motion, which allows me to strengthen, right? Like super, again, I'm not, you know, maybe because we're older and we've been doing it a minute, but right, like I'm pretty simple. If I can keep pain under control and get post-operative pain managed, it's pretty easy to get the motion I need, and then I can do anything else after. So then my sling is my counterpart to do that. And cuff, it's usually not a problem early, but for sure in that 3+ week, once they start to sleep a little bit, they're like, oh, I feel pretty good. It's a little bit, I grew up on a horse farm, so it's reins, right? It's a bit and reins in their mouth to kind of, and it sends two signals. It reminds them that, hey, I had surgery, and it keeps somebody from coming up and, you know, whacking them. So I don't, when I think, and my bias, like, again, I've athletic training a long time, put a ton of people on slings. Like I find the abductor pillow, a small abduction pillow, much more comfortable and easy to wear than just a simple sling, and sleep in and just manage. But it's a really, for me, it's an important part, but it's around patient pain control and comfort, and then self-modification and restriction, right? So the patient can manage their activity and not probably do too much.
Sure. So you mentioned it a little bit already, Chuck, about like when you feel comfortable starting. Again, like I'm with you that I don't believe that anything you're doing is passive, right? That it's all active. There's even quote unquote pendulums, which are, you know, supposedly, you know, viewed kind of universally by physicians as this, like, you know, minimally activated exercise. You're still getting cuff activation with it, right? So, but tell me, you know, when you feel comfortable initiating it, and then again, obviously, again, it's going to be different depending on cuff condition, integrity, size of the tear, that kind of thing. But let's just assume, let's go middle of the road, assume like medium-sized tear. What planes are you moving them in early? And then at what point do you usually transition to starting active range?
Yeah, no, great question. So look, I'll a little shameless plug, and it's not really me. Like I was the purveyor of the information, and I don't think there's a lot of research that's been there. We just had this discussion with our, so the ASSET, the American Society of Shoulder and Elbow Therapists, we published a consensus statement in 2012, and I think 2010 is the instability. And honestly, like there's new literature, but I don't know that it changes with the caveat of biologics. That's not on our agenda, but we might be worth I'd be interested in your experience. I think it's the new thing that's confounding in this. But that said, that table that Bryce Scott and Tim Ole pulled together that kind of has this progressive, all the exercises, for me, that's how I think. Like it's literally in that progressive piece of how do I gradually increased loads. And so I think about it in three ways. One is, given the size of the tear, so using that medium, that kind of 3 to 4 centimeter tear, I know that I can't come across the body and I can't come past the belly button or behind the back for, let's call it 8 to 12 weeks, right? I've got a period of time. Let's just pretend like I've got some period that I have to limit lengthening. So then, I'm probably going to keep them below 90 degrees and in rotational planes in that first 6 weeks. For me, I don't see a lot of advantage of strengthening above 90 degrees and surely against gravity until 6 to 8 weeks. What I'd say is whatever period I'm willing to sort of take the sling off and let them go. Now, if they meet my criteria, then you can strengthen overhead. And so if I think about what I learned from patients who don't progress, I think they're actually the most instructive, is if you look at patients that aren't able to maintain and do strengthening overhead, it's usually they either have a mobility problem, right? They don't have enough external rotation and or internal rotation, just capsular volume, or more common, they don't have that force coupling we talked about with the non-op.
Yeah.
To resist that internal moment. And so everything then, so now I go, okay, what I need to make sure they're able to do to get their arm overhead at 6 to 8 weeks, what I need to make sure they've got enough mobility, take that off the table, and I need to make sure they're able to use the posterior cuff, they're able to use their subscap, and they can do it in parallel, and I need to make sure that they can kind of perform that lawn chair progression. Because if I get their deltoid working, now I fix the cuff. It's the same progression as non-op, except this time, guess what? I have a cuff intact. So now I just need to gradually engage that cuff and turn it on, make sure they're using the scap, give them some advantage. And patients do really well. And then, because if I can get them to 6 weeks, no pain at rest, they're sleeping at night, they can do their therapy, and they get a little sore, but it comes back with some ice and rest, I'm winning. And so I really try to set that as the goal in that 6 to 8 week time frame. Hey, Dan, your goal at 6 weeks is we want to have 30 degrees of external rotation. I want you to raise your arm a little bit overhead. You can start to get to the top of your head, and you're able to sleep at night. That's our goal. That's what good looks like.
Now, when you say raise your arm overhead, are you talking supine or are you talking?
Yeah, sorry, great. Supine, right? I'll say, look, at 6 weeks, we'll start to put it on the top of your head and see if you can do that sitting up, but it'll be really hard. And then at 12 weeks, my goal is to give a touchdown. Now, look, it's not a perfect touchdown. It's just to kind of get to 120 or so of active elevation and be pain-free, back of your head, back of your buttocks, and be able to do most of your daily activities. That's our 12 week. And I really try to set that in a line with goals, because now the patient goes, okay, this is what good looks like. And I think it becomes a really important touch point, because typically that 6 and 12 week, right, somewhere 4 to 6 and then 9 to 12 tend to be the follow-up with the surgeons. Yeah. And what I want to know is, as the surgeon, are they saying the same thing in the office? Because we need to say the same thing to the patient of what good looks like. And it becomes a very important reinforcement of managing progression, because it's one of the reasons the patient specific functional scale is not the greatest ever, because the patient's like, oh, I just want to be able to do X. This is the most important thing. But you check that off and they're like, oh, I want to be able to do, whatever. And you're like, well, you didn't say that 6 weeks ago. And they're like, oh, I'm not any better. And I'm like, well, yeah, you are. Don't you remember you couldn't sleep?
Yeah.
So I think it's just a matter of helping the patient set some guardrails and targets, which then inform sort of my interventions and how aggressive I'm going to be with strengthening. I can't leave this section without saying I am a no pulleys guy unless you have an impairment or disability that requires you to do that. And I'll be frank, like, it's a super small number of patients that I've ever had to be like, okay, you don't have another option. But right, just as a reminder, and this is Tim and Bryce's EMG work and summary, like, pulleys have greater EMG activity than almost any of our other forward elevation exercises. So I think it's really important. I know it's nice and it's easy to give, but like that's a no-go for me, because I assume that Timmel, who's actually, I think, headed to retirement, but as good a shoulder therapist as the world's ever had,
yes,
I'm assuming he knew how to instruct patients as good or better than I can in the clinic, and for sure better than the patient's going to do it at home. So if he's getting that level of EMG activity in under supervision, whatever I'm getting at home for this patient using pulleys is probably not as good. Sorry, I had to have that PSA because I hate pulleys.
I totally understand. I'm actually that way with wall climbs, because that
oh yeah, they're in the same bucket. If you look, they're in the same.
Is like the most butchered exercise. You know, they'll come sometimes with a surgeon that tells them, yeah, now you can start to climb your fingers up the wall. I was like, sure, you can do it, but put your hand on your upper trap.
or just go and lift your arm.
And put my hand on your lower back and see how much you're extending your trunk through the lower back to do this.
It's awful. You'll appreciate being adjacent to a physician group. There is a surgeon that I've worked with, and if I had a nickel for every wall walk handout I've thrown away, I could retire. I wouldn't be showing up. Like literally, I'd be like, "Who gave you the exercise?"
Yes. And on the same note, kind of in the same vein as that, Chuck, you mentioned it a little bit with internal rotation stretching, because I feel that's another like polarizing thing with some of our post-op cuffs. We have, admittedly in our practice, we have some surgeons that start internal rotation stretching behind the back day one on the eval, or that want that. And I'm always, one of my functions is to kind of orient some of our new grads and that kind of thing, and kind of familiarize them with our post-op protocols. And I always get the question from them, well, you're not doing it, but the protocol says internal rotation stretching behind the back on day one. So, and I was like, yes,
for sure.
It does say that. It says that, but I don't feel super comfortable doing that. So
I don't think those words mean what you think they mean.
Yeah, right. So I wanted to kind of get your thoughts on that. And then I think you mentioned it already, you just don't like doing that stretch initially. So how do you kind of integrate internal rotation stretching? And then at what point do you feel comfortable kind of progressing it? Because obviously, reaching behind the back is a functional demand, but, there's probably no more movement that strains the cuff more than that, or at least for a posterior cuff repair, right? So
for sure.
Tell me a little bit about your progression.
Yeah, look, it's probably, I think, one of the more challenging, and I try to manage expectations around how fast they're going to get that. In my mind, this is a really important area. Where were you before surgery? Before your shoulder started hurting, what could you do? Because if they couldn't wipe and toilet or fix their bra or get their wallet for 10 years, and now they're going to have surgery and they expect to do it, like, whoa, wait a minute. Yeah. I think it's one of those things, right? Like, I think just asking a patient, how long it's been since they've been able to do that. So with that caveat, if I assume they could tuck their pants up behind their back, similar to the other side, within 6 months of having surgery, all right, now we can get there. And then I'm like, okay, that's one of the last things I expect to come back to normal. And it'll be somewhere in the 3 to 5 month range. And then really as the size of the tear gets bigger, the longer it's going to be. I've had a total knee at 45 and have done really well. And what I'll say is, look, it took me a year to get what I'll call full motion back, because every day I worked, it was fine, but it was a gradual, low load, long duration stretch. So I think for me, the first thing I look for is, can you get to the belly? Can you comfortably take your sling off, rest your hand on your belly, and then lift your elbow? I don't know why, I guess, be able to lift your elbow up, right? Can you get what I would call normal internal rotation at 0? Yeah. And then typically, right, rotator cuff patients shouldn't have volumetric loss. And so if they don't, right, some gentle joint mode starting 4 to 6 weeks allows me to maintain capsular volume. Now I'm just stretching the cuff, which is what I want to do. And if that's true, it's just gradual, and you just let them keep working on it, right? You can pick your method, a little towel. There, I do actually like kind of walking behind, but I'm not going to start that till probably not sooner than 6, but really 8 to 12 weeks.
Yeah.
And super easy. Now, the caveat is small cuff tears, if they have other additional work or things that are going to limit internal rotation, maybe I'll be a little more aggressive, but that's the exception, not the rule. And what I find is as long as I can get enough capsular volume to get at or near 90 degrees of abduction, then you'll have all the capsular volume you need, and it's gradually stretching a musculotendinous unit. In contrast, the truly stiff cuffs, for whatever reason, their capsular ligamentous structure has become stiff, which is a different patient, right? They've lost capsular volume, and that's a different patient. And actually, in that consensus statement, Mike Schaefer did a really nice job laying out kind of how you figure out stiff or pain. And for that stiff patient, right, now you're healed, you're in that 4 to 6, different patient. We're going to get down and dirty. We're going to have to do some pretty aggressive stretching. I might even go to a low load, long duration device to get that motion back. But that's rare. I mean, and it's what actually, Brad Parsons, there's a number of studies that have shown, even if you're stiff up to 6-7 months, it comes back by 1 year, right? There's a very small population. And so I think just managing patients' expectations that it's a pretty long lease on life to get there. And this is a 1 year recovery. It actually goes back to my pre-op, like, hey, you're only gonna do therapy 4 to 6 months probably, but this is a 1 year recovery. And just, that's got to be the statement. And I don't know that a lot of patients walk out of signing up for surgery with that expectation.
Right. Yeah. And looking at some of the studies now that are kind of comparing early versus delayed motion, right? It seems like at that, like you mentioned, at that 1 year mark, they all kind of end up in the same place, right? Like, for the most part. So,
Yep.
I wanted to find out, Chuck, do you kind of view horizontal adduction similarly to internal rotation?
Yeah, the one thing I'll say is once we get 6 weeks, from my view, it's not capsular. So it's really nice and easy. And as long as they're pain-free, sleeper stretch is really for frozen shoulders and throwers, but that's a whole other thing. I don't tend to do that in cuff. I don't find they need that deep posterior capsular stretch.
Okay.
And so, for me, scapula block, kind of quarter turn, lifting the arm up, or even probably for most cuff patients, the wall, leaning on a wall is plenty of stretch for them.
Yeah.
To kind of regain, because it is really important for forward elevation, and it's an early indicator if lat and teres tightness is going to be a problem for getting your kind of terminal elevation.
Yeah. Okay. So then that's probably a good segue into the next question, right? Which I had for you, which, what do you see in your mind, kind of from what you see from a patient standpoint and from the literature, what's the most common postoperative complication or impairment that we see following cuff repair? Again, assuming standard, kind of middle.
Yeah, right. It's probably the too big, right? You have probably a patient doing too much or having a fall or something and having a re-rupture and secondary. And then I'm biased, the surgeons I work most closely and I'm most aware of, we don't have, I say this, and of course I'm not in clinic all the time anymore, so I'll get yelled at for causing problems, but we don't have stiffness problems, right? It's just not in, but it's because we're very aligned between surgeon and therapist of when to be aggressive, when not. It's just a rare occurrence. But I think, when I think of bad outcomes, it's the failure, right? It's the re-rupture, re-tear.
For sure.
And look, I'm older. I guess I'm conservative as the day goes. Everything else I can get better. And worst case, a resurgery to clean up some scar tissue. I can't there isn't a great solution for therapy or there's no additional surgery that makes the patient better than they were at the first surgery. It's just not like second surgical outcomes are never better than primary surgery.
Good. Yeah.
Right. So I think that's my bias. So when I think about complications and ditches, that's it. In particular, I get to the massive and larges, right? Like now you're talking about a reverse, and after the reverse, like there's not an option, right? So I think it's just I think we get, especially if you see a lot of post-ops, it can become a little routine, and we forget how the fragility of the patient on the other side if there's a complication. So, my bias is, our job, yes, is to provide exercise, but it's really this advisor during this post-operative phase so patients make good decisions. And I recall a wrestling coach that I had a hard time with. I wanted to make return to sport decisions, and we would, go at it. I'll never forget one of my mentors said, look, your job is to make sure he doesn't make the wrong decision. Oh, so, my job in the clinic is to make sure that the patient makes the right decision and they have the right education and information to do that, right? And so it's changed the way maybe I think about post-operative guidelines and what my role in that is.
Yeah.
Which is probably a little different, right? Than when I first got out, it was my magic hands and what a great therapist I was. When actually, right, my ability to convince a patient that I could help them and this approach would help them, and probably helping them manage themselves and understand how to do some basic self-management exercises, probably what gets people better. It's a little offensive, right, when you've got a doctorate and you've gone to school for way too many years.
Yeah, definitely. And, my issue when I first got into blaming myself for every patient failure, right? Oh, what could I have done differently, right? Never mind that the patient ditched their sling at 1 week post-op and was painting ceilings, so, right. So I wanted to kind of segue to the next thing, Chuck, if we can, following, that kind of progression of the protocol. When do you feel comfortable starting resistive exercises, whether it's bands, dumbbells, whatever? And I guess, do you have a preference with that?
No, I'm a dumbbell guy over bands to start, just because, right, there's really good force length tension curves, control all the reasons. Yeah. But I think more importantly is actually that they've completed the lawn chair program. And so, it's both and, right? Based on the size of the tear, it's somewhere 6 to 10 weeks. Typically, that 6 to 8 week mark is sort of the adding active and resistance exercises, but it's just the progressive loading concept, right? So I think sometimes it's not that magically at some time point I can throw a band in their hand. It's have they demonstrated the physical capability to go to the next stage, right? We play board games at my house, and so, right, have you completed the level to go to the next level? And so I think just having those clear criteria, which for me, I'm typically looking for 3 sets of 30 of whatever exercise against gravity in that plane. If you can give me that, I'll give you the next hardest thing. It's not perfect, but it's a consistent way between patient performance and then symptoms and soreness after. Because if I can teach the patient to do that, now I just got to give them exercise and they progress. So I really think about the lawn chair program, dumbbells and side-lying external rotation. And then even with bands, I'm going to start with isometric walkouts. So can you resist the band first? Yeah. And then I'll let you go full range with the band, right? So, but again, it's back to basic exercise principles and loading.
Sure.
Right? Isometric, isotonic to isometric hold to eccentric. And I think sometimes we skip steps because it's a magic timeline.
Right. Yeah. I mean, just like we see with ACL all the time, right? Time out from surgery should not be the criteria, right? Yeah. They have to demonstrate some amount of motor control.
That's weird. I've never heard that.
Yeah. Right. Yeah. Well, some orthopedic surgeons might argue that. That's a separate conversation, but
for sure.
Yeah. So we have kind of a paradox in our practice because the majority of our surgeons, I think, prefer TheraBand stuff beginning at 12 weeks. But I feel like the exercise that I see butchered the most is probably TheraBand external rotation, right? I mean, again, I see trunk rotation, right? I see people kind of working triceps, elbows extending, right? And where are you feeling that? Right here in the biceps. Then you're doing it wrong, right? So
yeah, and look, I do think this is where digital adjuncts, which is a whole other discussion, but look, I don't know if you guys use an app or exercise videos, but like actually, this is where some of the RTM and other virtual supports actually so helpful.
Yeah.
Because hey, do you look like that, camera or not? Like, and so I think just the importance of teaching, and that's why for me, I teach the basic moves, right? I'm going to teach you to do side lying external rotation, no weights first.
Yes.
And then all I have to say is all we're going to do, we're going to stand up, you're going to put a towel roll under, you're going to do the same thing, right? Yes. It allows patients to learn how to move. And that's where you ask about key movements, right? Do they know how to isolate internal, external rotation, and then external rotation to elevation? Like for me, what I learned, if I can teach a patient to control external, internal rotation, then they can elevate all day long, right? And so it's just that, and look, my patients know, like, hey, elbow in, wrist out, arm up, like sort of that feedback allows patients to move well and be able to kind of, achieve the things we want them to do.
Yeah, you get that carryover for sure. Yeah. So one thing I want to ask Chuck is, in so many of these patients, we see this concomitant scapular weakness, right? Which again is going to kind of limit their overhead motion, right? So I wanted to find out from you, what do you think in your mind when we see some of these patients with chronic cuff issues and related pain, that kind of, what do you feel like is the driver for that concomitant scapular weakness? Is it disuse atrophy? Is it just the alteration in the scapulohumeral mechanics? Do you think there's something else from like a neurological inhibition standpoint? What do you feel like is the...
I think there's probably two buckets. I would put one is, we talked a little bit on the non-op, right? You've got this adaptive scapula group, whether it's pain, tightness, and we'll come back to that one. The other, though, I think this is what's really important, and there's a few patients, right, that always stick with us that I'll never forget. I had a full thickness cuff tear come over, and they sent him over for non-op, and I'm like, and he's like, oh, scapular dyskinesis and full cuff tear. I'm like, he has scapular dyskinesis because he doesn't have long thoracic nerve. So I think in these patients in particular, if they had any sort of trauma, I can't emphasize enough the importance for a follow-up exam, and especially whether it's non-op or post-op, of just super simple myotome, dermatome testing in our post-op patients. Like, I think sometimes you walk by and think, oh, they just had surgery. No, they just had surgery. The biceps tenodesis is super close to a whole bunch of nerves right there. Like, hey, and look, it's not by intent. They put retractors and protectors stuff. Did they tension the nerve? Did something happen to cause a little palsy or delayed? And so I think just having our minds there to always check it. And again, don't ask me how I know, because I found out the hard way. I'm like, oh, why is this post-op patient? Oh, wait, they've got their axillary nerves freaking out. Anyway, but I do think there are some patients, right, that have suprascapular nerve impingement, and there's some reasonable work out of a number of different places. So some nerve releases help cuff function. So I think when we get that patient with a non-responsive cuff, they can't isolate the cuff, we have to kind of drop back and go, hey, why? Right. Rule out the worst, and then come back to the adaptive. I think the majority of it is adaptive, and then understanding, is it pain driving it? Can I isolate, right? And typically I find it's why I take everybody back to the line, chair, and prone program. If I take them back to the basics, almost always they can fix this. Because we tried a guy at Drexel, Dave Ebaugh, longtime PT, and he and I both in our PhDs were trying to figure out how to fatigue serratus anterior, independent of the cuff. here's a spoiler alert. You can't.
Yeah.
Because it doesn't function without the cuff.
Without a cuff.
And so
yeah,
I think
sure.
but the vice versa is true, is for different reasons, people can't activate. And right, there's some different technology that is okay. I'm not super big on it, but interesting biofeedback though, to get the cuff to engage and then use the cuff, right? You do have to have proximal stability for distal mobility. I don't know if you ever heard that. It's a new concept.
No, never. Yeah. New concept, right? Yeah. So that's, you just mentioned it a little bit, Chuck. I wanted to find out from you, like, because you've got such an extensive research background, what do you feel like, what are we missing or lacking right now in the kind of overall body of shoulder rehab evidence, especially with cuff? And what do you feel like, in your mind, like, what's the next frontier? What's the next thing we need to solve?
Yeah, I think from where we are at, what I see, I've gotten much more population focused, and it actually takes us back to the beginning, right? A lot of the world we're in, I'm trying to find and define what's the value of physical therapy there, and it's actually on two ends. I think it's our ability to diagnose and triage early for non-operative or musculoskeletal conditions that need progression, and actually to manage at that level. So I think our ability to identify those patients early that need other things, and then how do we find efficient ways to provide that care? And I'm pretty bullish on virtual remote monitoring, leveraging technology to be able to support our patients. Of how do we do that? Because I think the reality is, in most of our world, I don't know if you've heard, there's a hiring crisis in therapy. There's not enough therapists. And so there's more patients that need our help than we can serve. So I think the question is, how do I leverage technology to do that? And then in the post-operative settings, the same. There's a recent study in JSES showing that, almost no therapy for reverse total shoulders gets people better. And look, I have a whole long list of questions and comments, and I know a number of the folks involved, and we've had really fun discussions over a beverage. But look, I think it does raise the question, what's the right amount of therapy to get the best outcome? And I think those are the two things for me that I think are probably most pressing, of where I think we add the most value to our patients, and then overall to the healthcare ecosystem and thereby society.
Yeah, that's right. I was at, you mentioned the technology piece. I was at the Isokinetic conference back in May, and one of my big takeaways was that AI is coming for my job. So I'm just hoping.
It's fascinating, right? But
it's fascinating and a little depressing at the same time. I'm just hoping to make it to retirement before it actually happens.
Yeah, I'll steal a Drew Contreras statement. With technology, AI will not replace. It won't replace. It'll replace the therapist that can't use it. So, right, our question is, how do we leverage those things to make us more efficient and do that? And that's the tension of where we're at, right?
Yeah. But you mentioned it. I mean, again, like this idea of like, okay, are there risk factors, and can we do some data mining to tease out like, okay, this person's going to do well with non-operative rehab because they're demonstrating this, and this, right? So I think, definitely you can put it to use, right? It's just a question, like you said, of finding the right way to integrate it to really improve our overall outcomes. But it was concerning how many people talked about AI, and I worry that pretty soon somebody will be able to just type in ChatGPT, and you could probably pull up 5 or 6 decent rotator cuff exercises that somebody would do pretty well.
No, you can. I mean, I played with it a little bit. It's a little scary. I think for me, that's understanding how do I actually add value, and like today at least, AI can't replace my 30 years of experience. No, it will in time. And so then really, I think, what are the ways we add value? And it's really around this coaching and how do we help more patients to do that? Because I'm very bullish on therapy. I think we add a ton of value in society, and in particular in musculoskeletal. And so I need technology to help me do that, to have the kind of patient impact we're looking to have.
Yeah. So on that note, Chuck, tell us, like, in your mind, right? I want to get into a little more personal note here. What's next for you in your research, the kind of pipeline here? I know, like you said, you've kind of broadened some of your roles with what you do with ATI right now, but in your research pipeline for 2025 and beyond that, what do you have in store?
No, thanks. So I think really, with IMISCA, the Institute for Musculoskeletal Advancement, and our team is really probably more on the population health side. What are real world impacts of large populations, in particular, probably with a bent towards integration of virtual remote therapeutic monitoring? How does that affect? And I think the other is, what is the effect when you leverage a standardized classification and training approach? Can you reduce variation in care and improve outcomes, manage utilization, and do those things? So I think those are probably, probably the broad areas that our team's spending a lot of time on of doing, and then probably with an underpinning of implementation. How do you do it in an efficient way and scale it to allow people to, to make it translatable, right? To get it from nice journals and dorks like me to like to talk about it, but actually in the everyday practicing clinicians' hands so we can help patients.
Yeah. So tell us, Chuck, outside of your kind of research domain, right? What's one thing you personally or professionally are trying to kind of improve on or discover professionally here in 2025?
Oh, no, that's a great question. I think it's really around continuing to see the big picture in healthcare and where PT fits in.
Yeah.
I'm fortunate in my role to talk to people outside of PT that have no idea actually what we do. And so I think really doing a better job telling our story. So I think, how do I capture the essence of the value that PT brings and kind of be an advocate and share that out in the larger domain outside of the PT realm.
Awesome. And then lastly, Chuck, just again, kind of personal anecdotes here. Tell us something about you that we won't find on the ATI PT bio for you on the webpage here. Any other hobbies, interests?
I really enjoy, so I've got a teenage daughter that loves to garden and outside, and she's my buddy. And so she and I have a garden in the summer. So I've got fresh okra and tomatoes, and we have watermelons and cantaloupes on the way. And so I guess going back to my country boy roots a little bit, it's not a big garden, but I enjoy a little bit of gardening.
Cool. All right. And what's the so you said you've got okra, and are we we cooked anything up from the garden yet, or is it still a little too early?
No. Let's be clear. I'm from the South. I only eat fried okra is the little fried okra. We've had some fresh tomatoes. Has been to date what we've had fresh. So I think got zucchini on the way soon, and then the melons will be a little later this summer.
And the big question is, she's into gardening. Is she actually into the food prep and the culinary side of it, or just likes to grow it and then,
she's in the food prep. We don't grow it. There's a large fig bush. She's taken and made some fig desserts. She loves to bake. So, I'm happy to eat anything she wants to cook.
Yeah, it's a win-win, right? You're
fostering
her hobby and her passion and benefiting her from the same time, right?
That's right. That's exactly right.
Awesome. I appreciate all your time here. I know I've taken up a bunch, and I feel like, again, I could probably pick your brain about 8 million more shoulder things, but I know we both have other responsibilities.
For sure. That's good. I appreciate it, Dan. I appreciate the opportunity to check, and I can happy to geek out anytime with you. Thanks for having me.
Awesome. Yeah. Always love the chance to chat with you, Chuck. All right. Have a great night.
Good. Thanks, Dan. I'll talk to you soon.
See you, Chuck.